Faculty members and all the delegates, thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Infertility, IVF, IVSI, Embryology Practice in Independent Bharat, organized by Women's Health Forum in association with Delhi Gynecology Forum. And the series is Kal, Aaj aur Kal. So let us start the webinar with Saraswati Vandana.
Good evening, everyone. It is my pleasure to welcome you all in the evening of Kal Aaj aur Kal series by Women Health Forum in association of DGF. Infertility management has witnessed a remarkable transformation over the years, which was once limited to conventional treatment. To start with, we are today having Brigadier Sir. We want to have blessings of Sharda Jain ma'am before we start. She is mentor and teachers of teacher for us. Dr. Sharda ma'am, please. Your
I think
experience counts for us.
I call Brigadier Sharma as guru of IVF. He has taught hundreds of gynecologists and hundreds of embryologists he has trained, and I think he's a history in himself. And all people around me are all trained by him. So I have to only say this word from him, and I'm waiting to hear. I've heard it before, but I'm waiting to hear from him again the story of how infertility has evolved. In my time, there was no infertility clinics. Till the time I left medical college, let me be very frank with you, there was no infertility clinic even at Lady Harding Medical College in 1990 when I left. So, with this particular remark, I will like Dr. Archana to say a few words before Dr. Sharma takes over after Sujata's introduction.
Dr. Archana is president of Women Forum. Please, Dr. Archana.
Yes, ma'am, very rightly said. Infertility makes a woman complete. And because unless and until a woman have a child, she will never feel like a mother, and which is very, very much needed for a completion of a personality. And obviously, madam, when we were a student, India was facing mainly the contraceptive problems and the population explosion problem. And later on, when the things changed, and now we are having a lot of infertility patients and infertility issues. So this really, and today with the iconic teacher, Dr. Rajkumar Sharma, Brigadier Sir, and our salutes to him. And as Madam said, he all have been taught by him. And when I saw his CV, I was really, really impressed, and I wanted to really introduce him. But let the Sujata Agrawal, the infertility specialist from Agra, from Delhi, do the honor. Welcome, Dr. Sujata. And welcome everybody and all respected teacher and all the friends. We really want to have you more and more with us, and please be always there and keep seeing the Women Health Forum. We post daily all the YouTube, also the recordings also, and the link also to join the webinar. Welcome all.
So Dr. Sujata Agrawal, she's chairperson Infertility Ki Pathshala DGF, senior consultant Apollo Hospital in the press, and vice chair ISAR Delhi. Please, this is now our privilege to invite you to introduce Brigadier R.K. Sharma, sir.
Thank you, Dr. Taru. And with folded hands and my respect to all the seniors and dignitaries, it is my privilege to introduce Guru of our DGFS and Infertility Ki Pathshala, Brigadier R.K. Sharma, sir. He is currently Medical Director, My Institute of Reproductive Medicine and IVF Center. He is he has done more than 10,000 IVF-ICSI babies. 10,000 is such a big number. Congratulations, sir. He is founder, director, ART Center at Army Hospital, Ara, Delhi, and Command Hospital, Pune. He was awarded with Vishisht Seva Medal by President of India in 2010. He is recipient of Lifetime Achievement Award 2022 by Delhi Gynae Forum. He was former General Secretary of IFS. He is recipient of Jagdishwari Mishra Award by Foxy. He is advisor for ART programs at multiple medical institutes, including AIMS Delhi and Maulana Azad Medical College. And it is my privilege to welcome you, sir. And the topic he's going to cover is infertility, IVF, ICSI, embryology practice in independent India. So welcome, Doctor.
Thank you,
Sharma.
madam. Thanks for the nice introduction. I do not know how much I deserve, but I will definitely like to convey my sincere gratitude and thanks to Dr. Sharda and madam and Dr. Archana Verma madam for inviting me to talk about Aaj, yeah, Aaj, Kal, and again Kal, Kal, Aaj and Kal, of IVF. And there actually, you really can't talk, about the past, the present, future separately because they all overlap each other. And something, the foundations made in the past become the building of today, and the building of today becomes the institution of tomorrow. So, keeping that in mind, I will try to not only cover few topics, but also would like to give my own lifetime experiences on those topics. And let's hope we all, enjoy the talk. And now, see, before I start my talk, I would like to pay my homage and ode to all the animals who helped to understand the reproduction. Now, way back in 1780, the Lazaro, he, inseminated a bitch with the dog's semen and produced the first, litter of pups. So you can imagine the ART in the animal model started way back in 1780. And the horses, the pregnant mares gave their blood to get the gonadotrophins. The rabbits, they gave their eggs and all for studies by the physiologists. And the mice were the one, where we could do the gonadotrophin tests and all. And the bovine serum was used, as late as 1990 to add into the culture medias. So all these animals, deserve, and their contribution deserve to be recognized, because after having work on these animals by the physiologists, we came to our past, that was the birth of the first baby, and then the story started, and today we are where we are today. Now, if you see the early days of ART, what we had was to understand when the woman would ovulate was only the basal body temperature recording. Now, this is very interesting. We know that, the progesterone is a thermogenic hormone, and once you give progesterone, the temperature would rise by 1 degree. So recently, one of my patient came. She's from Russia, and she was having repeated IVF failures at many places. So she thought that she has got something new to tell me. Doctor, do you know something about the basal body temperature? Can that be done in my case so that I know that my hormone levels are all okay? Then I told her, yes, I have done it in 1980s, and this is how you interpret the basal body temperature chart. And it's very interesting because nowadays we are not doing it. But I think if we add this into our clinical practice, we would know that, how the estrogens are, having a plateau levels, or there are, mountains and valleys in that. And if there is a, abnormal rises and falls of estrogen during a stimulation or in a natural cycle, we know that cycle is likely to fail. and also the progesterone levels. We are doing the blood test and all. We even by the basal body temperature chart, we can even predict the pregnancy early if we find that the progesterone rises and it remains high. And then progesterone, for withdrawal during the amenorrhea. And another very interesting thing that time was the postcoital test, because many times, it was thought that it is a woman's problem and no male would come for investigation. So how would a doctor know that the sperms are all right or not? So we encourage the women to have intercourse based upon their basal body temperature chart at the time of ovulation, and looking at the cervical mucus. So then we would aspirate out the cervical mucus within 6 hours of intercourse and look under the microscope to find if there are 5 to 6 motile sperms. We know that the male is most likely having a normal semen parameters, and we can go ahead with the investigation of the woman. Then followed by that was the HSE, and the digital HSE gave a little better view, because there, from oil-based the media, we are using the water-based media, and we could see the rugosity of the fallopian tube. We knew that the tubes are patent. We also knew that the morphology inside the fallopian tube is normal, so less likely to be infected because of tuberculosis. And diagnostic laparoscopy helped us for correction of the possible tubal problems and to identify and treat the endometriosis. So at present, we are doing the oocyte assessment by AFC and the AMH. This not only tells us about the number, it also somehow gives us indication of the quality of the oocytes which are expected. The uterine cavity assessment by 3D ultrasonography, saline sonography, and hysteroscopy. Now I remember way back in 91, when Bumsi Wadia doctor, he came to Trivandrum. I was posted there as a, early budding gynecologist. And he showed, the inside of the uterus in the medical college in Trivandrum. I was so fascinated by looking at it. And for him, actually, laparoscopy was the main forte for him, because he was involved in the laparoscopic sterilization. And he introduced to me, frankly, the views of hysteroscopy. Otherwise, in books, I'd seen it. But I never knew that we could see the uterine cavity so well inside. Then the tubal assessment by CIS and hysterocontrast sonography, and use of color Doppler has added new dimension, not only to see the tubal patency, but also to assess the endometrium and the follicular growth and right time for giving the trigger. And at present, we are moving more to the mild and moderate ovarian stimulation protocols. We realize that it is not good to have many oocytes, and out of that, most of them would be in the GV stage or the M1 stage, and put the patient at the risk of OHSS. The agonist was the protocol earlier, and then we switched over to antagonist protocol. For poor responders, the dual trigger gave a more M2. The freeze all, the protocol helped us to manage better results. The PGT in indicated cases and endometrial receptivity markers, not only by ultrasound, not only by color Doppler, but other biochemical methods also helped us. And how much they are useful, we'll be talking about them individually. And oocyte cryopreservation, especially for the patients who are suffering from malignancies, or now, which is a bigger problem today, is that many girls are postponing their marriages and pregnancies. So fertility preservation is very important part of ART today. In future, what I see is that artificial intelligence would help us in selection, and also the stimulation and embryology, and then assessing the day of transfer, and also predicting what is the outcome likely to be. The uterine transplantation has already started, though it may not done many cases, but in times to come, I'm sure, like it will become as common as a kidney transplant. And treating the genetic disease by genomic editing is likely to be the future. Now, this was my first slide, and I will be expanding on these now one by one. Now, the central story revolves around the past, which was how to make the fertilization possible. because IVF at that time focused on overcoming the biological and technical barriers to conception. And then we moved on to the present, how to optimize every step, whether it is ICSI, blastocyst culture, vitrification, fertility preservation, PGT, time lapse, and modern stimulation protocols, and the concept of OHSS free clinic and single embryo transfer, so that the morbidity and the mortality could be decreased by having a single embryo rather than having the multiple pregnancies. The future is basically will be revolving around the prediction, personalizing the protocols, and to make it automated protocol. So AI would help us, and the uterine transplantation and genomic technologies will push the ART towards the precision medicine. Now, in the beginning, before 1978, yes, we celebrate the first IVF baby, but the lot of physiologists, they worked very hard in the conditions in the laboratories to understand that yes, the sperm and egg both are required to make a baby. Otherwise, initially thought was the sperm contains a micro child, and the uterus is just like a grass field, and you put it and the baby will come out of it. And a lot of experimental work was done by the physiologists on these animals, and that was the basis. Based on that, the Louis Brown came as a product of collaboration between a clinician, Dr. Steptoe, and Bob Edward. Now it is very interesting, Dr. Steptoe was introducing laparoscopy. He was a pioneer in the laparoscopy that time, and he was giving a video presentation, and by chance Bob Edward was sitting in that lecture hall. And when he saw, that you can see the ovary, you can see the uterus with the help of laparoscope. So he suddenly realized that this is the way he can get the oocytes. Because in the animals, you could sacrifice and take out the oocyte, but human beings, you can't do it. So he immediately, when he saw that, so he knew that now this is the time he can do work on the human model also. And even before the lectures completed, he went behind the lecture hall and caught hold of Dr. Steptoe. And that was the beginning of collaboration between a clinician and the basic scientist, that is the physiologist Bob Edward. And the rest is a story. Now, initially, when they did the experiments on the infertile, their own nurse was there. The first pregnancy, they stimulated with the gonadotropin. HNG was the only thing which was available that time. And that too, from the pregnant mare serum. And they could get the oocytes and they could fertilize. But unfortunately, there was a ectopic pregnancy. So they postulated possibly when we give gonadotropins from outside, that it may be affecting the endometrium. So that is why ectopic pregnancies happened. The next time when they did the ovum pickup in this same lady, they did not use it. Was a natural cycle IVF. So this is a story, little bit of Louis Brown. And then over the years, we know about the India that yes, we were the second one to have a IVF baby in the world. Though, and it's not only it was the second IV baby, it was the first frozen embryo transfer. So that also, credited to the Indian scientists. So by 1980s, there was a clinical expansion throughout the world, and many of our Indian doctors, they went abroad to learn from Dr. Steptoe and came back and started the IVF center in Bangalore, in Bombay, and Chennai, and Calcutta. Already, it was in advanced stage. So that added on to this thing. And we had only 4 or 5 IVF cycles by 1980s. And the IVF laboratories became a dedicated clinical environment. It was not anymore normal experimental labs. It was a proper IVF laboratories. And by 1985, assisted reproductive technologies emerged as a defined field. So now it became a sort of super specialty in the gynecology as a assisted reproduction technologies. So the birth of the first IVF baby transformed fertilization from a laboratory experiment into the clinical possibility. So this is the picture we all are used to it. At that time, the laboratory was built around the control. What was the control? Incubation. The CO2 incubator, which were warm, water jacketed systems, or culture that was simple media, which got progressively optimized. I remember the initially, see the animal models, they did it on the basic salt solutions. And then they started understanding the physiology and they started making artificial culture media. When I started way back in 94, the B2 culture media was the only media which was available. And we were using this culture media for semen preparation as well as for, IVF, the whole, and day two or day one was, the time for embryo transfer at that time. The microscopy helped us for manual observation and micro manipulator. Now, there's another story about micro manipulator. They were already existing before the IVF, and they were used in the metallurgy, and the geologists and all were using it very frequently. So, Japanese, Narishige et al., they realized that we want to see like in the metallurgy without touching the the genetic or the gametes. So they use this micro manipulator and devise a mechanism so that now we could see the oocytes, we could see the sperms live, and we could, also micro manipulate them. So from metallurgy to IVF, the micro manipulator came. And then the environmental issues were there because that time, initially, because it came from the normal laboratories, but they realized that the oocytes and the embryos, they require a controlled environment. So they became a different, suits separately. So the OT and the lab, they came together, and then they were independent units, not part of a normal gynae OT. So there was a key shift from IVF became a systemic problem, not only a fertilization problem. Now, what do I mean by that was that now you had to fight with the system to have a dedicated OT. You had to fight the system to have a dedicated lab, and both of them to be together in one place only. And the anesthete is coming to your OT. Now I remember when I started the IVF program in FMC in 94. So everything was in place, though it was all jugaad. But the main problem was how to get the anesthetist from the comforts of the OT outside and give anesthesia in my OT lab. Because for them, the main OT lab, they have all the facilities, they have all the mechanism to deal with emergencies. Going out of that and doing it in a OT which is not as well equipped. So it was a very difficult job for them, and they somehow I got a message that nobody will come for giving anesthesia to your patients. But then that I think the God designs everything for you, whatever has to happen in your life. My gynecologist HOD, she was married to the anesthetist. So when I told madam this is a problem, he said no problem, I'll tell my husband. So we got the anesthetist and we could do the first ovum pickup in a British era old labor room which was converted into IVF lab and a OT way back in 94. So this was the type of, the laboratories where the experiment started. And then subsequently, we now know that we have a modular OT with the high-vac air conditioning system. Now, gonadotropins, initially, because Stepto thought that, gonadotropins are not good because it mismatches endometrium and the embryo. But then they realized that without giving gonadotropin, the natural cycle, having one oocyte, the pregnancy rate was very poor. So there was a reinvention or reinterest into the gonadotropins, which became a cornerstone in the management of infertility. So in 1931, as I mentioned, the horses, the pregnant mares gave the serum to get the gonadotropins. And then we thought, okay, take out the human, cadaver pituitary gland and get the, hormones from their FSH. But then the chances of normalities and, the disease transmission was there. So then the shift came to get the urinary from, old ladies in the communities. They would go and collect the liters and liters of urine, and out of that they would extract the HNG and then urinary FSH. And then because then there was problems. Many times the patient would have reactions with them, or they would not respond because of the added proteins. Over a period of time, they would develop antibodies against the FSH or the HMG. So you could keep on giving the high dosages. The oocytes will not grow. So then they realized that we need to purify it to remove all the extra proteins which are normally present in the urine. And then the hamster came to our rescue. The hamster cells were used for getting the recombinant FSH, and recombinant LH came subsequently. And then the filled by mass, so that, the effect was more. And over the years, by 2000, we heard about the long-acting recombinant human FSH, and now we have new family of pens so that it becomes patient-friendly and you could give most of the injections subcutaneously. The purity and the specific activity increase. So from intramuscular to subcutaneous to injector pens, that is how the gonode reference, progress over the years. Now, the IVF initially, when we were in the beginning of the career, we realized that the only thing which was available was HMG, and that also it was not readily available. So it was available only in the few bigger cities, because there were only four centers that time in India. So only there, and most of the time, the doctors would go to, say, England and get the HMG and bring along with them. I remember Dr. Sharda Jain, Dr. Sadhna Jain, Sadhna Desai madam told me that, that time there was no cryocans available in India, and they wanted to freeze the sperms over there. So she from Australia, she got this cryocan. So the custom people stopped her. She said, "What is this?" She said, "This is for keeping the milk." So they said, "Okay, you take it." Because otherwise she's scared, if they tell you we are going to do work on the human, they may stop it. So, the many people did, found the ways to find the, products back into India. So the HMGs came along with that. And then in 1980s, the urinary FSH and was being used because with the HMG, especially in the cases of PCOS, the response was poor. So urinary FSH, and then you know the highly purified FSH came. By 80s and 90s, the agonist came. That was a big relief, because earlier we had to track the ovulation. So you keep on doing the recombinant, you keep on doing the urinary LS test, and if you find that yes, there is LS surge, then everybody rush, go and take out the eggs over there. So there was no time. It could happen anytime, the LS surge, and then you had to go and retrieve the eggs. But by the agonists, when they came, so it was possible to have a better, timing of your ovum pickup, and because it could prevent the premature LS surge. And by 1990s, the recombinant FSH helped us to get better quality of the oocytes. So the agonists, they change the cycle control. Otherwise, as I told you, if there was a premature LS surge, there was a cancellation. And if there was no LS surge, you keep on waiting. So it was a very difficult for the scientists at that time to, control the ovulation, and before the ovulation, pick up the oocytes. So pituitary suppression was possible with the GnRH agonist. And later on, we were very pleased when we started getting the GnRH antagonists by 1990s. And it gave an immediate and a reversible suppression. So with the result, it was now less number of injections and better control over the cycles. Along with that, the laboratory also changed, and so did the embryo culture techniques. As I told you, in animal models, initially they used simple salt solutions. Then they tried to copy the physiological media which is present in the fallopian tube or in the uterine cavity to give more supportive media. And then sequential media came, which helped us to get a better and longer duration of embryo culture. And then the under oil culture technique came, so that we could control the pH, we could control the osmolarity, we could control the or prevent the infection getting into the culture dishes. So we get a extended culture so that blastocysts could grow from there. So the clinical consequence was that there was an increasingly supported development to day 5 to day 7 so that we could see the embryo. Because what happens, every species has got at some stage where the embryos would stop growing. So that's called embryo block. And in human beings, it is around 8 cell. Now, if the embryos grow beyond 8 cell, then they become little more autonomous and they become more sturdy. So we know that many of the embryos which were at 4 cell, which were transferring earlier than 8 cell, the pregnancies would not happen. But when they got converted into the blastocyst, we knew that the embryo block stage is over, and now the chances of pregnancies with the blastocyst increased. So slowly, we started moving from zygote to cleavage to compaction and the blastocyst transfer. I remember 94, 95 when I was with Dr. Sandal Sai Madam. Uh, so in my final stages of training, they asked me to open an IVF center in Bombay Hospital before, because I was working in a private clinic. So I was asked to, start, and I remember Dr. Paitungat sir, very passionate about gynecology and infertility. So he requested madam, and the already equipment was there. So I opened a small IVF lab over there. So there I created the embryos at the PN stage, and then they were transferred into the fallopian tube by Dr. Paidunga under laparoscopic guidance. So though the pregnancy did not happen, but the ZIFT which is there, which was mentioned earlier, now nobody does that. So the basic philosophy was that you put the early stage embryo in a natural place, which is the fallopian tube, and maybe the natural growth will be better and the pregnancy rate will be better. But since it is an invasive procedure, nobody does ZIFT or the zygote embryo transfer into the fallopian tube today. So we could now classify the embryos at various stages, from the PN stage to the cleavage stage to blastocyst, and Gardner grading system helped us grading the blastocyst, and this helped us in prognosticating that this pregnancy is going to happen or not, and also for the research purposes to compare the result from one center to the other center. The major leap happened when the ICSI happened. Before that, we were doing, especially in the male factor, when the sperm count was poor, there was nothing much we could do. So the only way was that the mechanical systems, by doing zona drilling, by chemical method, thyroid, or by when the micromanipulator came, injecting few sperms into the zona, below the zona in the perivitline space. Now the ICSI is another story. I'll come to that. And over the years, there were a lot of more indications besides the male factor, even unexplained infertility in the endometriosis. So there was a increased role of ICSI, and especially also in the surgically retrieved sperms. So it has become a routine tool in any IVF center. Now, sometimes, science moves forward in unexpected ways, and sometimes the breakthrough looks like a slip of the hand. And this is what happened when Dr. Palermo, who was working in the Brussels, um, then he was doing Susie. What is SUSI? That means subzonal insemination. You put 2 or 3 sperms in the perivitline space, especially when the count is very low, hoping that one sperm will enter into the ulima and cause fertilization. And by mistake, his hand moved and the sperm got entered into the ooplasm. And he kept it separately. He didn't tell his boss. But next day, when he saw that, yes, it was fertilized and it grew into embryo, so that is the time he told his boss, and then they realized that yes, it can be used in cases of male factor infertility, when the count is very low, or when the sperms are retrieved directly from the epididymis or the testes, so gave an option to the infertile couples to have their own biological child. The cryopreservation, initially, what we were doing was only the sperm freezing. And it again was initiated in the animal models, and because it was being used in the livestock and the horses and the cattle. And I remember in 1991, when I was posted in Trivandrum, and I went to Trivandrum, there's Dr. Forgetting his name, he was very keen into the infertility subject, and he was freezing the sperms. So I thought, let me go and see how he does it. And it was very fascinating. What he was doing was that he was using the white of a hen's egg and mixing it with the gently with the human sperm, and then they were freezing it. And post thaw, the sperms were still alive. So, I realized, yes, this is another way of freezing sperms, which was being done way back in 91, I'm talking in India. But then the freezing medias came, and by 1950s, the sperm freezing and early human cryopreservation happened. But it was not available in India that time, in 91, which I'm talking about. And subsequently, it became a common practice. In 1980s, the embryo freezing, the slow freezer technique was available, and it used to take 3 hours. So it was very taxing for an embryologist, and especially for me, because I was a clinician as well as an embryologist. So I remember after finishing my OPD, after finishing my normal the lab work, and embryo freezing was the last thing. I would start around 12 o'clock in the night after having slept for 1 hour, 11 to 12, and then get up and start doing the embryo freezing. And by 3 o'clock in the morning, I would go home. And the seeding time was the most important that time, because if you seed the carrier later or earlier, it will spoil the embryos. So we had to be very careful. Timer was put on, okay, this is the seeding time, get up, do it, and then again rest. Just keep on, putting the liquid nitrogen in the slow freezer. That was all what we were doing. And after 3 hours, it was put into the canisters. So by 1990s, because better cryoprotectants and the protocol refinement was there, so it started getting optimized. And still the embryos were, that time slow freezing method was used. And later on, when the vitrification came, and that one, really changed the, I would say, the sleeping hours of the embryologists, because within 1 hour maximum, with all the, paperwork, you could do the vitrification and store the eggs and maintain the record as well. So the slow freezing, which causes ice formation over a time, so that was harmful to the embryos. Vitrification prevents ice crystallization. It makes a glass-like a substance in the cytoplasm of the cryoprotectant concentration is also higher, and that gave a better survival rate of both the oocytes and the embryos. So with this, the past becomes a platform for the present. So by the end of the early IVF era, the several capabilities had converged. As I told you, it is not one. There's so many things always happen together, and we can't really demarcate the past from the present and present from the future. So there was a control culture, support development of the beyond the cleavage stage. So and ICSI, the cryopreservation, the blastocyst culture, the micromanipulation, and dedicated lab all helped us to come to the present. So what is the present? It is no longer one intervention. It is an integrated chain of laboratory and the clinical decisions. From the gamete selection, from the fertilization, whether IVF or ICSI, and controlled embryo development, culture techniques, the selection of the sperms, the embryos or the eggs, the morphology, studying by the time-lapse technique, the PGT to select the best embryos, and cryopreserve for future use, and transfer whether fresh or frozen, depending upon the indication. So every step today is an opportunity for quality control, selection, documentation, and progressively data-driven decision support. The culture system of today are conventional or the drop culture technique, closed systems, extended culture to get the blastocyst, the sequential culture media, and the time-lapse culture media. Now we are coming back, we started with the single step culture media. We are coming back again to the single step culture media. Let the embryo decide what it wants. So we have come back to the circle again. And the modern lab is not only heavily equipped, it is also giving the right environment, right temperature, right humidity, so that the no infection should occur and the embryos can get a right environment to grow. The various type of culture dishes have come in the market, and also the PIXI and the IMSI helped us in a very bad male factor infertility cases to select the right sperms. So the embryo selection is a problem because what we see is basically in a blastocyst expansion, inner cell mass, trophic cell numbers, and morphology. But what we want is the viability, whether it is implantation potential or whether it is aneuploid or euploid, or whether what is the life potential of this embryo. So this gap between the visual morphology is a proxy for the complex biological competence. So time-lapse PGT and AI is going to help us in selection of the right embryos. So now when we do the time-lapse system, we are seeing the how the cytoplasmic granules are moving, how the cells are dividing, in which directions, what timing and all. So based upon that, we can, with experience and now with the AI in times to come, we'll be able to select which is the best blastocyst for to be transferred first to get a pregnancy. The PGT, initially, it was for single gene diagnosis, then for PGTA for aneuploidy assessment. And today we do the trophectoderm biopsy, but then it all causes injury to the embryos. So we are moving more towards a cell-free DNA approaches under new circumstances, that is non-invasive PGT. So you take the spent fluid or you take the blastocele fluid and do the study and make out whether it is a healthy or abnormal embryo. So trophectoderm biopsy, I will not go into the much of it, the procedure, because time is less. So I'll move ahead and we just take out that the cells. Now you should do the laser, shots away from the inner cell mass, so that the heat should not go towards the inner cell mass, because that is the one which is going to form the baby. So vitrification changed the role of cryoablation to freeze all strategies. For frozen embryo transfer, you can plan according to the patient's requirement. For fertility preservation, also the repeated use, so the patient need not be stimulated again and again. So we could store the embryos for future use as well. And also, especially, where the fertility preservation is required, especially when they want to postpone the pregnancy or when the malignancy is there. So one can use either the mature oocyte retrieval and then frozen, or the immature oocytes and then they are in vitro matured and then frozen, or the ovarian tissue preparations into cortical strips. But for that you can't do vitrification, you need to slow freezing technology. So it has come as a mainstream ART thinking. And so now the question is not that can we treat fertility now? The answer is that can we preserve reproductive options for later? So there is a paradigm shift in our thought process. The modern ovarian stimulation protocols have come. So basically the aim is to have a milder stimulation, more patient friendly, and also for the poor responder, the duo stimulation technologies. And also to prevent the OHSS and to have at least, pain to the patient. So more, injection-free treatment would be, or lesser number of injections, especially in the antagonist protocol, we can use that. And now the oral antagonists are coming. So with the result, which are already being used, and there are some papers coming that can be used in IVF also for the down regulation pituitary gland. endometrial preparation, and we are moving away from the basic ultrasound to also to select which hormonal preparation to be used and to see which receptivity markers. I expect that times to come, we will just have a strip. You take some cervical mucus, put it in the strip, and it'll tell you whether it's receptive or not. So now, does really the implantation window matters? Pregnancy can happen in the ovarian tissue. It can happen in the, over the peritoneum, over the gut, and also in the human beings. It has been found. The conclusion of this research, the various reviews of many papers since 1980 to February 2026. The conclusion was the extrauterine pregnancies constitute natural experiments, demonstrating that the human implantation is more flexible and embryo driven than the window of implantation paradigm allows. So I always say if your embryo is healthy, it will implant anyway. Only thing is if the endometrium is very poor, that means if the soil is poor, you increase the number of seeds, number of embryos. But now we are, not allowed to put more than 2 embryos, so that will be a issue. So oral antagonists are now in some papers have come where they've used it and they found they're as good as cetrorelix. But only thing is for them, you should not give agonist as a trigger when you are using oral this thing, Relgolis, because otherwise you will get less number of eggs. So you require to give SCG to get more mature eggs. And also, if already the LS surge has happened, the Regolis cannot immediately downregulate it. So the injection would be better in these cases. The recommended LH is a new, the molecule which we are using it, especially where there is a congenital LH and FSH deficiency and as genetic polymorphisms, or with acquired LH and FSH deficiencies such as pituitary suppression regimes, or in advanced age, or when the patient is having a lower ovarian reserve. Now, since the patient, most of the time, they complain of pain. So we have now corifolitropin alpha, though it is not available in India, but it can give you folliculogenesis for 7 days. So you need not give every day. Every 7 days you can give it. And then the oral FSH also. So that means you don't have to give an injection. So now the oral FSH receptors, which are now being used in the mice models, and the two of them are available. I am not going to detail at present, but the safety profile so far doesn't show any toxicity in the mice model. Maybe in the times to come, we'll be having oral FSH. So we'll have oral FSH, we'll have an oral antagonist. So the patient would be having a more patient-friendly regime for treatment. So in vitro maturation, though it would help, it is indicated in cases, especially in OHSS or when the time is short in the cases of malignancy to take out the eggs early. But you require a specific expertise, counseling, and informed consent because the in vitro mature eggs may not form as many embryos as the mature eggs. So the present is ICSI, blastocyst culture, vitrification, PGT, time-lapse FET, fertility preservation, and artificial intelligence now, which is emerging. And the future is basically the artificial intelligence would enter in various, points like patient selection, oocyte, sperm assessment, embryos assessment, grading, uterine assessment, and the outcome prediction. So in embryo selection, it would be used, and the sperm analysis and selection, and also the sperm selections, live we can do it. So this is already available. So where the motile sperms are individually seen, and the machine would select which is the best sperm out of these, and then you can use it for ICSI. So along with the time lapse, the artificial intelligence is, and along with the PGTA screening, it is going to give us, embryo selection, which would give more chances of pregnancy. And it will also help us in the embryo grading and also the embryo selection later on. So conventional plus AI-based embryo selection is the new way for times to come. And it may also predict, but at present, it ranges around 59 to 84.4%. It requires more improvement and more, studies when it can be used to predict the outcome. And also for the uterus assessment, it will be of use. And however, there can be data bug because AI tells you what you are fed, what goes in, what that comes out. So the data entry is the most important in the AI. It would augment the doctor, but it will never be able to replace the doctor or the embryologist. So beyond IVF, NIPGT, IVM, uterine transplantation, artificial uterus, and genomic editing, and artificial intelligence at various levels, which I explained, is going to be the future. And uterine transplantation, you already know that it has been done. Not very many cases, but in India also it has been done. But it has got its own challenges. I will not go into that. And artificial uterus is going to be the one which is going to liberate the woman from all the agony of pregnancy and the labor. And already it has been done, at certain stage of the lamb development. And I'm sure in times to come, it would be available for the human beings also. Artificial oocytes and artificial sperms are also likely to come in the near future, and where the patients can use their own ovarian stem cells or fetal gonad cells or germline stem cells or pluripotent stem cells to develop the artificial oocytes. And it would be of great help, especially to have our own genetically related offsprings. So the future of fertility management, as I mentioned, because there are some patients who would have some genetic disorders, they would require the genetic editing. So the CRISPR technology will be used to remove the abnormal genes and replace with the normal, and so that baby which is born is normal. So the disease is not carried. So there are a few papers which have come which explain this method. But however, we don't know where it is indicated and how this technology will compare with the genetic testing method and what are the ethical considerations along with that. So the future should not become more data and less better decision, higher accuracy with lesser clinical benefit, automation but without autonomy, prediction without certainty. The future of ART should be evidence-based, clinically validated, and patient-centered. To summarize, the potential that AI will usher in a new era of standardization, optimization, and precision to IVF are endangered wide enthusiasm and has even gained traction in the commercial arena. So many companies are now coming with this, and approaching us to, selection of the sperms and selection of the embryos. So we should wait for the, times to come and let it be validated. While application of AI embryology has gained the most attention and show great promise, it is likely to its use will widen to other aspects of reproductive medicine. And uterine transplantation will be as routine as kidney transplantation, as I said earlier. And genomic editing will eradicate many diseases. So IVF laboratory in the future will be patient friendly. It would have a automated gamete assessment, the embryo assessment, the endometrial assessment, and then AI will be used for decision support. And the final interpretation, however, will be done by the embryologist only, and the quality control would remain the center of any IVF laboratory. So this, in a nutshell, is how the future ART will look like. And the fundamental shift is from doing IVF to understanding and predicting IVF, optimizing each step, and then making the prediction and personalize the treatment. So the key takeaways from today is the past. The IVF succeeded because the laboratory learned to control the reproductive function. The contribution of the physiologists and the animals is there. At the present is the modern ART integrates ICSI, blastocyst culture, vitrification, PGT, time lapse, and individualization of the treatment. And future holds AI and emerging reproductive technologies, which would give predictability, personalization, and reproductive options, and would require validation. So since 1978, the problem was how to make the fertilization possible. Today it is how to optimize the results, and in the future will be to predict and personalize and automate. So the message is the future of IVF is not about replacing the clinician embryologist. It is about giving them better information for deciding the best for the patients. So last slide. What is my dream? My dream is that infertility is a preventable disease because lifestyle, the sexually transmitted infections, the tuberculosis, and early gamete freezing, especially somebody is postponing, would prevent the infertility. And it should be accessible to all. So my dream was initially to bring IVF to the government setup. So I got it because that time people told me AIMS doesn't have IVF center. How can Army Hospital have it? Because AIMS is supposed to be the best one. But then I had to put in my blood into it and got the into the armed forces, and then many medical colleges followed it, and I dreamed that it should come to every district hospital so that it should be accessible to all, and it should be affordable to all section of society. So once the oral medications will come, I'm sure the cost of treatment will decrease, and the government will also have to put in to have no excise duties or custom duties if any material is coming out from the outside. And proper training and upgradation of skill is very important. Otherwise, one learns to live in the cocoon of comfort. One doesn't upgrade. And if you do not upgrade, you always degenerate. So ethics and self-regulation is most important. Today, what we have is the government-driven regulations. Now, those brings again, uh, the intervention and um, registration, Raj, the control, which possibly will not help the patients. So we as a doctor should have a self-regulation mechanism so that no external forces, can put a finger on us, and we should do work ethically and as per the morality for which, we have been trained for. So in the end, I would say that we can create the body, but we cannot give it a soul. We may be playing God, but we are the gods. Thank you very much.
Amazing. Uh, Amazing lecture, sir. First of all, I think a comment by respected Dr. Sharda Jan, madam.
I think you said amazing is a short word. Uh, and I think, your last slide has been absolutely great. I also feel that, in future, people will freeze their gametes early, and the rest will be artificial uterus, and it will be available everywhere. I think, as I can see things become simpler and simpler, and that is the future going to be as far as fertility is concerned. Uh, I do not know what is going to be in the future, but at this particular time, we are at the right time that we have everything. But still, the success rate is around stuck around 50-60%, but it has to be increased. So I think whatever you have thought about it, I am not thinking about it just like a renal transplant, the uterine transplants will come. But yes, artificial uterus will come. Artificial uterus will come, and this Elon Musk says it will be reality all around. So I think, I'm not going to be there, but I'm sure from the heaven I will be able to see
No, no,
that.
you'll be there only, ma'am. Because see, with the artificial intelligence, what has happened? The research has, the time has become very small. Earlier, it used to take years together to get the result out of your research. Now, within hours, you can get the research result. So, with the result, we will see artificial uterus in our lifetime only.
Yeah. Yes.
Veenacharya, please comment.
Yeah, very good evening to all. It is so mesmerizing talk. And I just want to share that when you said about the 1978, that was my question in my RPC. Who's the first born baby? Baby Brown Lewis. So that I come out on that day, my in examination, they asked me this question. And I also witnessed whatever the journey you have showed. But recently we heard so much about because recently the uterine transplant doctor has come to Jaipur, and he said कि recently the twin baby is born, and the baby is actually normal, and there is a lot of research is going on. So आज और कल की जो हम बात कर रहे हैं, and in Japan they have prepared the artificial womb. So हम ये सोचते हैं कि हमारी साइंस तो कब की थी, जब कौरव के 100 पुत्र आर्टिफिशियल वूम में पैदा हुए थे. That was the science we had. All the 100 Kauravas were born outside. So the science is, so whatever the witness we have, so our mythology is definitely there, and there something is, but research is going on. We definitely hope. Last time Dr. Sharda and Dr. Malhotra gave the talk in the Jaipur. He said how they prepared the womb outside and how much it is going to successful. And Japan is doing, and they are showed nowadays. So that is the tomorrow which we are going to see what is going on. But wonderful talk, and very updating our from the what we had yesterday, today, and tomorrow. That is very eye-opening talk. Thank you, doctor.
Thank you.
Dr. Bakshi, if you're here, you want to comment? Dr. Bakshi? Archana, over to you.
Yeah.
Yes. Madam, really, this talk was like watching a Transformer movie. So much
Yeah.
history, evolution, technology, and transformation, and connecting Kal Aaj. Or Kal, as sir said, it is a platform that was the Kal. And now, wonderful reminder that the medicine keeps transforming, and we must keep learning, adapting, and upgrading ourselves. Otherwise, uska deterioration hona hai. And all the possible things and possible futures. Oh my God. Uh, Sir has talked as if like a brigadier would have conquered an army.
The Pakistan
So,
Army.
Yeah.
yes.
We have
So,
few youngsters,
not a single point left.
Sujata, Sweta, if they want to comment, the
Thank you
youngsters.
so much, sir. It was really wonderful. एक second के लिए भी पलक झपकने का मन नहीं किया. I have
हाँ,
never heard
yes.
any talk better than this in like IVF का कैसे evolve हुआ. हर चीज from basal body temperature से आपने कैस्पर टेक्निक तक हर चीज इतनी simplified करके बता दी. Thank you, sir. Thank you with folded hand. अगर हमारी CME होती तो हम सब आपको standing ovation देते.
Yeah.
और यहाँ से
Yes.
हाथ जोड़ के दे देते.
Still today,
Thank you, sir.
even here we should. Yes,
हाथ जोड़ के
wonderful.
दे देते
डॉक्टर,
हैं.
इन्होंने IVF इतनी मुश्किल से सीखी है, कोई टाइम का मतलब ही नहीं था. 2 बजे, 3 बजे.
दूध का डब्बा बोल के क्रायो प्रिजर्वेशन का लेके आए मैम. मतलब that is really amazing
Great.
Yes,
story.
बिल्कुल सुजाता, सच में he as sir said, he was a clinician also, he was an embryologist also, and working all throughout the night.
रात में
This
12
needs
बजे से काम
dedication.
करना मैंने, and 10,000 babies you have given to society.
Yeah.
That is really
Big.
thank you sir.
Thank
And
you.
he has got a golden hands, and his success, just pours on his
So
patients with his
polite
hands.
मैम, एकदम smiling face और ऐसे मजे से बताते रहते हैं और सुनते हैं और कहानी सुना रहे हैं.
We want youngsters to speak.
That is
Dr.
art.
Sweta Saldana, you want to speak? Dr. Sweta?
Madam,
Yes.
unmute yourself.
Please unmute yourself.
No, you are not audible. In the meantime, Dr. Sangeeta madam can say.
ब्यूटीफुल प्रेजेंटेशन सर, नो वर्ड्स. एंड मैं तो इतना कहूंगी कि कल की स्टोरी तो बहुत छोटी थी, इसमें तो सारी स्टोरी आज ही की है जो हम विटनेस कर रहे हैं. कल वाज लिमिटेड ओनली अप टू पीसीटी, बीबीटी and hysterosalpingography and this thing, these things only, and the husband semen analysis. जो सारा डेवलपमेंट है वो तो कल से आज में ही हुआ है, जो हम सब ने विटनेस किया है. Means from an empirical treatment we have come to a evidence based and technology assisted treatment. So this is the basic change. और सर सबसे बड़ा चेंज तो सोसाइटी में हुआ है. एक बांझ औरत के नाम से हटके ये एक कपल डिजीज हो गई है. अ सिंगल वुमेन टॉर्चर से it has been declared, the woman has been given a dignity, and now it has become a couple problem, not a disease. And it has really changed the social life, social standing of a woman. सर मैं इतना कहूंगी कि दिस इनफर्टिलिटी
Yes.
मैनेजमेंट ने हमको बहुत बड़ा एक वुमन प्लेटफॉर्म पे बहुत बड़ी स्टैंडिंग दी है सर. सो कुडोज टू यू सर कि आप लोगों ने इन सब चीजों में इतना डेवलप करके एक वुमन को माँ बनने की शक्ति देखिए, उसको एक सोशल एम्पावरमेंट दिया है। थैंक यू सर।
Yes. सर प्लीज ये वाली स्लाइड जरूर ऐड कर लीजिए कि कंप्लीशन ऑफ अ वुमन, that she was suffering a lot, mental suffering.
Yeah, absolutely right.
I think we wind up, Dr.
Yeah.
Archana.
Yes, sir. Thank you, everybody. Thank you so much. Thank you, Taru. Thank you, Poonam. Thank you,
Thank you
Sangeeta,
so
madam.
much.
Especially our Sharda Jan madam. मैडम कल सारा दिन मुझे सपने में यही आता रहा कि मैडम ने क्या तो टॉपिक चूज कराए और क्या स्पीकर चूज किए हैं। मैम सचमुच kudos to you.
Wonderful. I asked the Milton, it was a mesmerizing lecture. Not
Yes,
a,
yes,
a minute, it is, I think it's a hard work.
Yes.
थैंक यू सर।
Yes.
मैम मैं
हमने
बोलूं,
IVF
आई हैव
जितना भी
जॉइंड इन
सीखा,
फ्रॉम अनदर
Dr. Salgana, please
फोन।
join. हाँ.
And सर
मैम
एक बार
तो
फिर से आपका लेक्चर ऑफलाइन भी सुनना चाहेंगे पूरा, बहुत
Sure.
मजे से
YouTube पे आएगा पूरा।
Yes,
so
नहीं नहीं
sir,
सर से सीधे सीधे सुनेंगे।
so for
हाँ
me, sir,
श्वेता।
this was like a eye opener. It was like such a mesmerizing talk, sir. ऐसे लग रहा था कि मैं किसी बड़ी सी कॉन्फ्रेंस में बैठ के कोई ओरेशन सुन रही हूँ। I mean,
It
your
was.
lecture and your talk, those 89 slides were like absolutely so well made. It was like I was walking through a story that how, हम जो book में पढ़ते हैं सारी अपने history and how what is the future. I mean, we all know that AI is coming into a big way. Actually got genomic imprinting, editing of genes, CRISPR technology. Sir, it was absolutely amazing. So we would like to hear this again once.
Okay. Yes.
Sir, please, sir, it is a request.
It'll be my honor, madam.
Thank you, sir. Thank you so much, sir.
Thank you. Thank you.
Thank you so much everyone. Thank you so much sir. ऐसा लग रहा है बायोस्कोप के जमाने से 3D पिक्चर में आ गए हम। Thank you so much sir.
सर के
मैंने तो
सेंटर में
पहले
जाके
बोला ना
मैंने
वो
पूना
3D।
में देखा है सर, कितना बाय गॉड काम करते थे, और जितने पेशेंट सर के आ रहे थे ना, सब सीधा पैरों में, सब सीधा पैरों में सर के।
ना
मतलब
सर ना ये
इतना
वाला
मानते ना सर
बेटा,
को, इतना मानते, वहां जाके आपको लगता है कि मतलब क्या सर की पोजीशन है, इतना
यस
काम सर ने
इवन
किया ना, कमाल ही है।
हम लोग भी ना रियली हम लोग, मैं तो अभी बहुत बहुत ज्यादा नहीं मिली हूँ सर से, बस मैडम से ही जब जब भी कभी मीटिंग होती है तभी देखती हूँ। अब तो सच में चरण स्पर्श करने का मन है।
नहीं नहीं, ऐसा नहीं बोला नहीं मैडम, आप तो देवी है, देवियों का अलाउड नहीं है मैडम।
I am in the queue. I am in the queue.
Madam,
सर
I'm
लिटरली
strong believer of Ma
लिटरली
Durga, and I see Ma Durga in every woman.
सर
So
महाराष्ट्र में
I have to
लड़कियां
touch the feet.
है।
I can't. Yeah.
Thank you.
I-
Thank you
दुर्गा
so
तो
much, sir.
बहुत।
थैंक यू।
Thank you, madam.
थैंक यू सर,
Thank
थैंक
you,
यू।
madam. Thank you.
ओके थैंक यू
Good day.
थैंक यू
Good day, ma'am.
गुड।